Bismillah wa salatu salam ala Rasulullah. Welcome everyone for joining us for the head and neck session. We are going to be addressing the situation when a new lesion appears during head and neck radiation therapy. This is Hussain Hussain, consultant radiation oncologist, subspecialized at head and neck and CNS stereotactic radiosurgery from the Department of Radiation Oncology at the Comprehensive Cancer Center in King Fahd Medical City. Next. So this is a 64-year-old lady who's coming to the clinic, presenting with diabetes and hypertension. She is having a non-healing right buccal mucosal ulcerative lesion extending from the premolar to the retromolar trigon, measuring 6 by 3 centimeter, with a right level 1B palpable enlarged lymph node. Next. This is the CT scan that's been done while assessing the patient that's showing a right buccal mucosal lesion invading the underlying buccinator muscle and subcutaneous fat, retromolar trigon, and the medial pterygoid muscle. There is an ipsilateral metastatic necrotic lymph node, level 1B, with extranodal extension, with multiple other ipsilateral metastatic lymph nodes involving level 1 and level 2. CT chest, abdomen, and pelvis were negative for any distant metastasis. Next. Pathology had been reviewed after obtaining a biopsy that showed a moderately differentiated squamous cell carcinoma. Next. Next. So the patient was discussed in the multidisciplinary tumor board that had been recommended for surgery. Next. Surgery was done through and performed a tracheostomy, wide local excision with marginal mandibulectomy, extraction of all teeth and dental implants, neck dissection of level 1 to level 4, with reconstruction of radial forearm free flap with a split thickness skin graft. The patient had recovered well postoperatively and discharged home in a few days. Next. This is the pathology findings showing moderately differentiated invasive squamous cell carcinoma with negative margins over 5 millimeter. There is a single tumor deposit within 2 millimeter from the anterior superior soft tissue margin within the muscle. All other soft tissue resection margins were free of tumor, including the pterygoid muscle over 5 millimeter. The distance of the tumor to the deep resection margin was 7 millimeter. The tumor was demonstrating the worst pattern of invasion, 5, where there is a small tumor satellite away from the main tumor, which is associated with a higher risk of disease recurrence. Depth of invasion is approximately of 9 millimeters. The tumor was abutting the mandible cortex, but does not invade it. There are right cervical lymph node that's positive for metastatic squamous cell carcinoma with extranodal extension. Right cervical lymph nodes, level 2A, and all the way of the other lymph nodes are negative, all the way to level 4. Pathological staging of T4A into a M0 on clinical assessment by radiology and all other investigations. Next. Next. The patient had been discussed in the multidisciplinary tumor board and was recommended for concurrent chemoradiation. Next. The patient was assessed by radiation and medical oncology, has been shown to have ECOG performance status 1, had a well-healed surgical scar with no visible or palpable oral, neck, or skin lesions. The patient was counseled for radiation therapy, for adjuvant radiation therapy of total dose of 66K and 33 fractions, and has been counseled by medical oncology for concurrent cisplatinum. CT simulation was done. Next. Next. These are the summary of the volumes that had been targeted for this patient. For the high-risk clinical target volume was involving the tumor bed with the right level 1B as it had an external extension. The intermediate risk volume showed, or actually included, the CTV 66 plus a margin, and including right level 2, which is the adjacent lymph node level to the involved lymph node at level 1B. So the adjacent lymph node was included at level 2. The lower risk volume of CTV 54 included the CTV 59.4 with right level 3 and 4 lymph nodes, and the contralateral side, level 1, 2, and 3, and 4, as the patient had a positive lymph node with the risk of retrograde spread to the contralateral side. You had to include it in the low risk volume. Next. This is a summary of the volumes. High risk volume. Next. Intermediate risk volume. Next. Low risk volume, as it chose to include bilateral sides. And as of the right side that had the positive lymph nodes, we have included the nodal level all the way to the base of skull of the jugular foramen. Next. The isodose cloud, as it's shown. Next. For the intermediate risk volume. Next. For the low risk volume. Next. DVH. Next. Those statistics for all volumes, whether the clinical target volumes or the organs at risk. Next. At the first week of the concurrent chemoradiation, the patient was tolerating the treatment very well. And after 8 fractions of radiation therapy, the patient was assessed and had been shown to have a skin lesion on the surface of the skin on the lip, on the lower lip, measuring 1 centimeter by 1 centimeter, that had appeared 3 days ahead of the visit, with mucositis grade 1 and mild odynophagia. Next. This is the lesion that had been seen during the first on-treatment assessment visit. Next. As of this presentation is being recorded, otherwise it would have been greatly an interactive session. So some of these questions have been put to initiate discussion, but we'll move through. Next. The patient had been referred for surgical assessment by her primary surgeon, seen within 5 days. Biopsy was obtained that came back to be well-differentiated squamous cell carcinoma. Next. Next. The patient was discussed in the multidisciplinary tumor board, and we have discussed all the 4 options. Interrupt concurrent chemoradiation, go ahead for surgical resection, resume concurrent chemoradiation with new treatment plan, versus complete the course of concurrent chemoradiation with concurrent cisplatinum, then go ahead for surgical resection. Third approach, to complete concurrent chemoradiation with replanning, then go ahead for surgical resection, or complete the concurrent chemoradiation with replanning, then close observation. Next. The patient was resimulated and had a new thermoplastic mask with 1 centimeter bolus to the site of the skin recurrence, with 5 centimeter to the surrounding chin and neck. So the patient had, if we go to the next slide, please. As you see, the CT sim shows the previous slide, please. Previous slide. No, the previous slide before. Okay, so yeah, just next. Yeah, so here you see that there is a differential bolus at the site of the disease recurrence. You see 1 centimeter bolus, and for the surrounding area on both sides of the neck, there is a 5 millimeter bolus. So there is a differential bolus differentiating to the risk of disease, and that those that we are requiring to have it received at the surface. Next. So this is the patient at the CT simulation with the mask on. And as you see, the black area is outlining the 1 centimeter bolus. The blue mark is outlining the 5 millimeter bolus. Next. 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 All right. So this is the new treatment volumes. The biopsy-proven new metastatic skin lesion had been included and considered as a GTV that had received a mean dose of 63.8 gray if we were to go ahead with the first plan to complete the 33 fractions. So if we went ahead with the first plan, it would have received only 63.8 out of the 66 gray that was planned for the initial plan before a recurrence appears. With the minimum dose would have been 48 gray and the maximum dose would have been 69. So we did not go ahead and continue the previous plan because we have this new pathology proven metastatic recurrent skin lesion. And the patient have been assessed that have received 29 gray over 15 fractions of the first plan. Resimulation was done adding 1 centimeter bolus over the lesion and 5 millimeter bolus at the surrounding skin area and both sides of the neck. The patient had received 15 fractions of the first plan, delivering 29 gray in total, and will complete the remaining 18 fractions using the new plan, defining the volume, which is using IMRT simultaneous integrated boost, as going to be described in a moment. There are 4 volumes at this second plan. The first volume is going ahead for 70 gray, with a total planned dose of 70 gray in 33 fractions, delivering 38.18 gray over the remaining 18 fractions, with a dose per fraction of 2.12 gray, so that we just pumped up the dose a little bit to cover and kind of compensate for the previous 15 fractions that have been received at a lower dose to the tumor, which is actually was just appearing after the first week of the treatment. There are 4 or 3 other volumes, 2 of intermediate risk volumes, high intermediate risk and low intermediate risk, then the low risk area. The total planned dose was 66 gray in 33 fractions, delivering 36 gray over the remaining 18 fractions, with a 2 gray per fraction. The PTV 59.4, total planned dose was 59.4 in 33 fractions, delivering 32.4 gray over the remaining 18 fractions in order to achieve that dose level with a 1.8 gray dose per fraction. The PTV 54 new, which is the low risk area, is a total planned skin delivered treatment of 29.45 over the remaining 18 fractions. So both sides of the neck, the skin on both sides of the neck, we treated it all the way to the sternoclavicular joint and to the clavicle. So this patient had a skin metastatic lesion from hair buccal mucosal carcinoma. This skin metastasis is at risk to appear anywhere else in the neck. So we went ahead, we treated with a 1 centimeter bolus the area of the existing gross disease and the surrounding area. Then we extended the 5 millimeter bolus to the rest of the neck so that if there is any potential of microscopic disease, anywhere in the skin would have been covered by the 5 millimeter bolus. So both sides of the neck were targeted at the skin and all the way at the deep tissues. Next. This is a slide that shows, if you see at the red area, the mapping of the disease with the bolus, as you see on top of that CTV. Next. This is the high-risk CTV. And if you kind of zoom in, you would be able to see the ghost disease. So this is the intermediate risk volume at the 66K. Next. The intermediate risk volume at 59.4. You can call it high intermediate and low intermediate. Next. As you see, the bolus is going to the neck on both sides. And this is the low risk volume. And we went ahead all the way to the clavicles. and level 5 on both sides. Next. Next, the isodose cloud, as it's shown for the high risk volume. Next. 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 This is the low risk volume. DVH. Next. Those statistics for all volumes, target volumes, and organs at risk. Next. How did the patient do? What do you think? Let's learn in a moment. Next. The replan started, delivering the 16 fractions to complete the remaining 18 fractions on July 2022. Treatment was completed within 7 weeks, 14 calendar days, with 2 times of single day breaks. The patient had developed grade 3 and grade 4 mucositis, so we had to have 1 single day breaks in order to help the patient to tolerate the treatment. The patient was on sodium bicarbonate mouthwash and pain medications in order to help her go through the treatment with concurrent chemoradiation. There was complete resolution of the metastatic skin lesion by the last day of the concurrent chemoradiation. So the last day of the treatment, the skin lesion that was shown on the first week of the treatment have completely gone and clinically not been there at all. Next. CT head and neck was done a few months later. That showed no evidence of residual disease, recurrence, or cervical lymphadenopathy. Next. MRI neck was done a few months later. That showed no evidence of residual disease, recurrence, or cervical lymphadenopathy. So now we are almost 6 months post-treatment. Next. This is a photo that's being shown after the MRI clinic, or after the MRI assessment. This is patient seen in the clinic, and it shows that the patient went ahead for the surgeon, and the surgeon have removed the area where the disease was there, so that we'd like to secure pathological assessment of the residual, or actually the recurrence of the disease, to assess if there is any residual or not pathologically. Are we so good so far? I hope that anyone is looking at this photo would be able to pick up something that might be of any attention. All right, can we go to the next slide? Okay, can we go back? Is everyone happy? I hope someone would have picked up a small lesion at the 7 o'clock position, or almost between 7 to 8 o'clock position. This patient had negative MRI, negative CT scan, pathologically secured at 6 months of the disease or the treatment completion, have secured, just go back to the previous slide, please. Yes, the patient have secured pathology that had been obtained from the area of the previous disease that is completely clinically gone. Pathology came out to be negative, but if you see the 7 o'clock position, there is this kind of vesicular-like lesion at the between 7 to 8 o'clock position. It was biopsy that came out to be skin metastatic lesion. So unfortunately, the patient have developed skin metastasis, and the patient went ahead for systemic therapy because this is systematic disease, and actually there will be no point of further local regional treatment. Thank you so much, and I hope that we can have further discussion at the discussion time. Talk to you in a moment. Thank you.